Good evening, everyone, and welcome to this 36th online teaching class under the banner of UP-RI. Today, the second class for the prostate cancer. For this, I am inviting Dr. Rashi Agrawal. She will moderate this session. Dr. Rashi, it is over to you.
Thank you so much, ma'am. It is our proud privilege to have Professor Dr. Neeraj Rastogi to teach us about localized prostate cancer. Dr. Rastogi is a professor in Department of Radiation Oncology in S.G.P.G.I, Lucknow. And he is a renowned radiation oncologist. And as we all know, in localized prostate cancer, radiation plays a major role. Over to you, sir.
Thank you, Dr. Rashi. I am thankful to Dr. Surabhi, Dr. Rashi, Dr. Ashutosh, and Dr. Shalin for giving the opportunity to speak on the prostate cancer for this class. So this is in continuation of the prostate cancer which has been taken by Dr. Kirti. So a lot of things which Dr. Kirti has already talked about prostate. We will not talk about those things, but to brief about the prostate cancers, some of the risk criteria we will be discussing again. So if we see the prostate cancer incidence, whether it is increasing, it is real increase or the artificial, because increasing awareness and the people, increase in the life expectancy, active PSA screening, and better diagnostic tool. As we have seen that it started from the 6-core biopsy earlier, now the 12-core biopsy is taken. So stages has already been discussed previously, and this is the TNM staging, which is 2010, is still continuing with the same. So Gleason is very important. Key, what is the primary pattern? What is the second most predominant pattern? Because this is based on the glandular architecture, and this glandular architecture helps them to decide what is the Gleason in these patients, and which helps them in deciding the risk in the prostate cancer. So whether prostate is T stage, whether extracapsular extension is there, whether seminal vesicle invasion is there. So it has been found in the invasion. You can very well find in the MRI. So this is the one of the very important slides which is started by the DMECO. What is the low risk, intermediate, and high risk? So prostate cancer treatment is based on the risk criteria. This is the older risk criteria. PSA is less than 10, Gleason 2 to 6, or stage T1CR2A. This is the low risk. Then intermediate is 10 to 20, Gleason 7, and stage 2B or 2C. And PSA more than 20, Gleason more than 7, stage T3 or T4. This is the high risk. And subsequently, after that, there's so many risk criteria have come based on the NCCN guidelines, ISMO guidelines, and European Association of Urology guidelines. European Association of Urology guidelines are more or less similar, and also ISMO guidelines also similar. But NCCN guidelines, they have divided the prostate cancers like very low, low, intermediate. They have divided into favorable, intermediate or unfavorable, high risk or very high risk. So these are the criteria is based on the, especially in the intermediate favorable, when they don't not require any hormone therapy, same as the very low and low risk. While the unfavorable intermediate risk, they require at least hormone therapy at the neoadjuvant, at the adjuvant setting. So the tumor burden as per risk criteria, based on the PSA, Gleason, and what is the, if PSA is there, what is the prostate cancer probability? 0 to 2, 1%, 2 to 4, 15%, 4 to 10, 25%, and more than 10 is about 50% probability of the prostate cancers. And the usually 4 to 10, 50 to 65% are the organ confined, while more than 10 The only 30 to 50% organ confined, rest is the beyond the organ. And Gleason also tells her about the risk of metastatic disease. 2 to 4, 20% chances, 5 to 7, 40%, 8 to 10, about 75% chances of the metastatic disease. And the tumor extent as per Roche formula, it tells about the what is the possibility of the pelvic lymph node involvement. This is the Roche formula. 2/3 of the PSA plus Gleason score minus 6 into 10. What is the chances of the extracapsular spread? What is the chances of the seminal vessel involvement? All these is based on the formula. But it was at that time when the imaging modality was not up to the mark. So subsequently, the multiparametric MRI or MRI has been very useful in telling the lymph node there, extracapsular spread is there, whether seminal vesicle involvement is there. So this is now maybe less relevant now. So depending on the prostate cancer, treatment depends on the watchful waiting or localized disease. So this requires active surveillance. Usually it is taken into the low risk disease with life expectancy is less than 10 years. It is usually done by the distal rectal examination, PSA usually 6 monthly, and MRI pelvis or prostate needle biopsy 12 to 18 months interval, and then at 2 to 3 years. If we see the change in the Gleason score, a rise in the PSA, then we do the active treatment in those patients. Localized disease is there. If a small disease, low or intermediate risk, either one has to go radical prostatectomy or radical radiation therapy. If large disease, intermediate or high risk there, so initially we give the neoadjuvant hormone therapy 4 to 6 months, and subsequently patient undergo the radical prostatectomy or radical radiation therapy, and followed by the adjuvant hormone therapy. So subsequently we will coming out the various studies which is available with the hormone therapy. So what are the indications of the radical prostatectomy? Low risk disease. What is the watchful waiting? Usually it is done into the low risk disease when there is a presence of the comorbidity, when age is more than 75 years, when life expectancy is less than 10 years. Usually it is done into the T1 and T2 N0 disease. But it is not the common preferred practice in US. And there's a large trial, a Scandinavian trial of 695 patients, watchful waiting versus the radical prostatectomy, and the results were published at 12.8 years follow-up. So what it shows that due to the any cause, 58% in watchful waiting versus the 48% in radical prostatectomy. So it is significantly difference. And death due to the prostate related is 21% in watchful waiting versus 15% in radical prostatectomy. And survival benefit is also seen in the radical prostatectomy group when the patient is less than 65 years of age. So watchful waiting is not a common preferred treat practice in US now. So these are the some of the surgical series which I have shown, and we usually the surgical series have a 10-year or 15-year follow-up data. Large series when you do the radical prostatectomy, this is the retropubic prostatectomy. At the time, robotic prostatectomy was not quite popular. So it is a large series. This is the large series of 3,000 patients. 10-year biochemical control of the disease is 52% and 15-year 40%. John Hopkins series 2,400 patients, 74% and 66% at 15 years. Memorial Sloan Kettering series, 4,000 patients, 73% at 15 years. And it's another series from Benaco, there's a 75%. And this has shown the very good results when we compare with the radiation therapy. Because all these patients were early stage patient which has been treated by the surgery, and radiation people usually have lower stage patient, higher stage patient, as well as high risk patients. So in radiation therapy, what are the options we have? Brachytherapy, when we have the permanent seed implant, iodine 125 or palladium, temporary implant, iridium 192 SDR, and the external beam radiotherapy, which has come into the various changes. Like they started with the conventional EBRT, followed by the three-dimensional conformal radiation therapy, then IMRT without imaging, then IMRT with online onboard imaging, like IGRT, when the combination of two, EBRT and brachytherapy. So first we will talk about the external beam therapy in the carcinoma prostate. Various radiation techniques of dose escalation were used. One is the conventional radiation therapy, 4-field box technique. Then changes in the various radiation techniques, 3D conformal radiation therapy, intensity modulated radiation therapy, intensity modulated with image guidance. So these are the few of the studies. Whether we add the radiation therapy to the surgery, what are the, so one is the SWAG study, which has shown if, and these are the patients which have either T3 disease or margin positive disease. If we do the surgery alone versus surgery with radiation therapy to the 64 gray, definitely the 10-year progression-free survival is 66% with this surgery alone versus 74%. They have significant OS benefit when we add the radiation therapy. While the EORTC study, there's significant difference in the biochemical progression-free survival, but no OS benefit. And in the Germany study, they have also shown no OS benefit, but the 10-year biochemical progression-free survival is significantly superior from the surgery alone. So another thing is whether we should give whole pelvic RT versus prostate only radiotherapy. There's two large study. One is the French study, is the GETAC-01 study, and second is the American National Cancer Database of 14,000 patients. So I will be discussing both the studies now. So first study was the RTOG study, when they have given the whole pelvis radiotherapy versus the prostate only RT. So 7-year progression-free survival. 7-year progression-free survival is 40% with the whole pelvic RT versus the post-op 27%. Significantly difference when you treat with the whole pelvic RT versus the prostate only RT. And the GETAC study is 444 patients. 444 patients, which have shown 50% of the patients in the GETAC study from French study is the high risk patient. Whole pelvic RT versus the prostate only radiotherapy. At 11 years of follow-up, there is no difference in the OS and PFS. In these patients, 4 to 8 months of neoadjuvant hormone therapy was given and followed by adjuvant hormone therapy for up to the 2 to 3 years. Another study is the NRG-RTOZ study, which is results is still awaited, which are shown given 4 months of neoadjuvant HER followed by the 30 months of adjuvant hormone therapy. So one of the largest national cancer database has taken 14,800 patients, whole pelvic RT versus the post-operative prostate only radiotherapy. There was no difference in the whole pelvic RT versus the prostate only RT in the increasing dose era, and the whole pelvic RT has been less tolerated, increased bowel toxicity, and other also toxicities has been shown in those patients. So there's at present there is no need of the giving the whole pelvic RT versus the prostate only RT in the era of dose escalation when we add the adjuvant and new adjuvant hormone therapy. So this is the patient which we treat with the this 4-field box technique or conformal techniques. And when we treat the conventional 4-field box technique, usually doses is going to the rectum and the bladder, which is difficult to avoid. So subsequently, when we treat with the conventional treatment versus the conformal, when we increase the dose escalation, then you cannot give the dose beyond 60 gray, 60 to 64 gray in the conventional technique. So to increase the dose, we have to give the conformal. To conformal, we can give about 70 gray, and subsequently we increase the doses. This is the conformal. When we can save the bladder, we can save the rectum, and we can also give the high dose to the prostate. So this is the dose volume histogram which we see. If we give the conventional technique, we can see this. We can see this is the triangle one, this is in the rectum, and this is the triangle in the bladder. Usually the dose to the rectum and the bladder is high in conformal, in conventional technique versus the conformal. 3D conformal, we can decrease the dose to the bladder and rectum. So these are the phase 3 non-IMRT studies. So phase 3 non-IMRT, which is a very important, the Lancet Oncology journal paper, which has given the dose of 64 gray versus 74 gray. So there's significantly difference in the 5-year biochemical control, 43% versus 55% when we increase the dose from 64 to 74. Another Dutch study, which 5-year biochemical control when 68, 78, dose escalation to 78, 33% versus 66%. Another Fox stage study, 70 gray versus 76 gray. So dose escalation shows that 64% biochemical control versus 70%. And Massachusetts General Hospital study, 70 gray versus 79 gray, 68% versus 83%. Memorial Sloan Kettering study, 65% versus 85% at 5-year biochemical control. When we escalate the dose, then the chances of the biochemical control is high, but may not be OS difference. These are the other studies, which are the non-IMRT studies, which have shown the dose escalation, also shown the similar 5-year biochemical control. So IMRT is a refinement of the 3D CRT. Usually treatment field is very highly, and IMRT gives the dose escalation with improved dose conformity and also decreased dose to the critical organs. So various methods which are used for IMRT in the prostate, like the with image guidance, like the ultrasound incorporated in the linac, kilovoltage X-ray on-board imaging, or mega voltage CCT, which is incorporated in the linac. And this is the IGRT, usually imaging before the radiation delivery, various clinic with the on-board imaging or clinic with the on-board getting, various IGRT equipments like tomotherapy, cyberknife, which has been imaging before delivering. So this another on-board imaging, when we see the KV images, when we put the fiducial gold marker into the prostate, and then we do the KV images and match all these fiducial gold markers before the radiation delivery. So what we do in the simulation in these patients, this is our practice which we take. Usually the patient is supine with semi-filled bladder. Usually the 500 ml of water is patient is asked to drink 30 minutes before the radiation therapy, and patient is also asked to empty the rectum before the bladder filling. And we use the ankle rest or knee rest. We give IV contrast and arms on the chest, and usually the 3 millimeter sections are taken from the L2, L3 vertebra up to the anal verge. And this is the gold marker. Usually these 3 gold markers are there in the AP image and the lateral image. These gold markers we match before delivering the radiation in these patients. So this is the matching tool. This is the crosses which show the matching with the gold marker in the lateral view, also in the AP view. And then we give the, either we put the gold marker or we do the cone beam CT. Cone beam CT we match with the doses with the prostate and take the CBCT during the treatment. And if we see, if we give the without image guidance, you can larger area of the bladder and rectum is also included in the field, but we give the IMRT, usually we give by the 7 or 9 fields. So you can see this so much conformal dose distribution into the prostate, avoiding the bladder and the rectum. So usually the conventional doses which we give 60 to 64 gray. In the conventional post-operative dose is also 64 gray. When do the 3D CRT earlier, 74 gray, and IMRT we prescribe usually 76 to 81 gray. And various constraints, Quantec recommendation, we take care of the bladder doses, rectal doses, small bowel, femoral head, as well as penile valve. So this is one of the study of the dose escalation with 3D CRT and also IMRT. This is the Zaleski paper from Memorial Sloan Kettering paper, which has shown same doses has been delivered 81 gray, but the toxicity of the GI toxicity has decreased with IMRT from 10% to 2%, and also GU toxicity 15% to 4% when you do the IMRT with the image guidance. So dose escalation we usually with the image guidance is must. These are the few long-term data of the IMRT. So Zaleski from Sloan Kettering given the dose escalation from 81 to 86 gray and biochemical control 70 to 85%. University of Chicago 76 gray and Mayo Clinic, they have given 75.6 gray, and another Memorial Catching paper is 86 gray, and another Cleveland, they have given the high dose per fraction 70 gray in 2.5 gray per fraction. So approximate 80 to 91% 5-year biochemical control. So the long-term data has shown that dose escalation is possible. They have started the dose escalation at every increment of 5.4 gray from 64.8 to 86.4. And they have found that dose escalation with 5.4 gray at every time, they have increased the, for the low risk, they have found usually the dose is usually 75 to 76 gray is adequate, but there is no difference when you increase the further doses from 76 gray to 81 gray. But for intermediate and high risk cases, preference is given to doses higher than 76 gray. Then the hypofractionation trial versus the standard fractionation with the IMRT. This is the very important CHIP trial. 3 doses have been given: 74 gray conventional 37 fractions, 60 gray in 20 fractions, and 57 gray in 19 fractions. GI toxicity 14% versus 12% and 11%. And GU toxicity 9%, 11%, and 7%. 5-year biochemical control is 88%, 91%. Like when you give the 60 gray in 20 fractions, 3 gray per fraction, quite high biochemical control within the tolerable GI and GU toxicity. Another hypofractionation schedule, like the in 35 gray in 5 fractions, stereotactic radiotherapy was given, and then there is no difference in the toxicity between the when you give the 35 gray in 5 fractions, and 5-year biochemical control was quite high, 81% at 5 years. These are the most of the prostate cancer were elderly patients, quite difficult to come to the radiation therapy center very frequently. So hypofractionation of radiation therapy is the standard of care in these most of the patients. And apart from the photon therapy, recently a lot of places they have used the particle beam therapy because they have taken the advantage of the physical advantage of the black peak and rapid fall off. And proton therapy usually 78 to 82 gray equivalent for proton, and carbon ion therapy 66 gray in 20 fractions. What they have found? Lower rectal and bladder toxicity. Rectal toxicity has decreased to 2% and bladder toxicity less than 5%. But 5-year biochemical disease-free survival is 85 to 90% with the carbon ion as well as photon. But there is no randomized trial between the photon with carbon ion, photon with the proton. So it has not found any superiority in the tumor control, but although there is a significant decrease in the bladder and rectal toxicity with the particle beam therapy. So what is the role of the androgen deprivation therapy, whether one should add or one should not add? There's many trials which have shown when you add the radiotherapy alone versus the radiotherapy with androgen deprivation therapy. So this is the studies, at 5 years, most of the studies have shown when you add the androgen deprivation therapy, especially in the intermediate and high risk cases, survival is superior. So what is our current practice of the IMRT with image guidance, which we have already discussed? We used to place 3 gold markers 1 to 2 weeks before radiation therapy, and movement of the prostate due to variable bladder filling. Usually give the 500 ml water half an hour before and rectal filling before the treatment. And so we can decrease the PTV margin around the prostate and the seminal vesicles. And usually we don't get the patients of low risk. So intermediate risk, we give the only prostate only radiotherapy with IMRT with image guidance using the fiducial gold markers, and usually give the short-term hormone therapy 4 to 6 months of androgen deprivation therapy 2 to 3 months before and 1 to 2 months after. And in high risk cases, same doses 76 gray and 38 fractions and with image guidance, and usually these patients require the adjuvant hormone therapy, usually 2 to 3 years. So what we have analyzed our data in comparison, we have treated till now about 120 patients. This is the data of 80 patients, which is dose which we have given 76 gray, and the follow-up usually the 7 years, and usually we have found the GI toxicity, we have slightly higher 7%, and GU toxicity, data toxicity is 4%, and 80% 5-year biochemical control in these patients. So what is the role of the hormone therapy in localized prostate cancer? Usually very low and low risk, there is no role of hormone therapy in any form. In high risk, yes, there is a role. Neoadjuvant hormone therapy 2 to 3 months followed by concurrent, and usually adjuvant hormone therapy 2 to 3 years. And intermediate risk, whether it is favorable, unfavorable, is usually the neoadjuvant 2 months and subsequently adjuvant 4 to 6 months. Usually the short-term hormone therapy is given in these patients. So when we see the various trials, EORTC trial 22991, RT alone versus the androgen deprivation therapy with RT, significantly improvement in the biochemical disease-free survival as well as clinical disease-free survival in the EORTC trial. So ADT in intermediate risk, NCCN guideline shows unfavorable intermediate risk, combine the radiotherapy with 4 to 6 months of androgen deprivation therapy, while unfavorable group, radiotherapy alone is sufficient. No need of adding the hormone therapy. ASCO, American Urological Association, ASTRO guidelines, they do not provide any specific recommendations for androgen deprivation therapy in conjunction with the radiotherapy in favorable intermediate risk, but unfavorable, one should give the short-term androgen deprivation therapy. Then the role of androgen deprivation therapy in high risk and very high risk cases. So this is the trial which shows that androgen deprivation therapy in high risk cases with external beam radiation therapy significantly decrease the disease specific mortality as well as time to distant metastasis. is decreased by the adding the androgen. And EURTC 22860 trial, this trial has shown the overall survival benefit with this, but long-term overall survival benefit in these patients with the high risk cases with the long-term androgen like 2 to 3 years. This is the whether one should give the short-term or immediately after the treatment or maybe delayed or at the time of relapse. RTOG 8531 shows that if you give the immediate hormone therapy after the RT versus the hormone therapy at the time of relapse, so significantly is superior when you give the immediate hormone therapy after the radiation therapy as adjuvant. So one should not delay the hormone therapy in these patients. What is the optimum duration of the hormone therapy? Whether it is 4 months, 6 months, 18 months, 24 months, or 36 months. So I will come about the various trials, what has been used. This is the 4 month of goserelin with flutamide, 2 months before and 2 months after versus 24 months of goserelin. Most of the trials have shown this significantly improvement in the disease-free survival, distant metastasis-free survival, biochemical failure-free survival, or overall. But there is no difference in the overall survival. So it shows that longer androgen deprivation therapy, 2 to 3 years, is superior than the shorter androgen deprivation therapy in the high-risk cases. Whether one should give the 18 months and is more effective or 6 months. This is another trial which has also shown that in locally advanced prostate cancer, usually the high-risk cases, short-term androgen deprivation therapy, 6 months is inferior outcome in the biochemical relapse-free survival as well as disease-free survival in these patients. So these patients at least require long-term androgen deprivation therapy, 18 months or more. One can so in this they have shown 36 months is found to be better, but there is more adverse effect in the androgen defect like cardiac effects and other androgen deprivation effect like osteoporosis increases with the longer term. But although biochemical relapse-free survival is improved in the long-term androgen deprivation therapy. So whether it is 18 months, so there is no difference in the disease-free survival, disease-specific survival, but disease-free survival and biochemical failure-free survival is superior when you give the long-term androgen deprivation. So what are the guidelines? ASCO, American Urological and ASTRO guidelines recommend treatment for the high-risk prostate cancer 24 to 36 month androgen deprivation therapy rather than the short duration of treatment. And 18 months for the patient which have the greater value for the quality of life. There's uncertainty into the disease outcome where the problem with the cardiac problems or there are a lot of comorbidity. In those patients, one can decrease the androgen deprivation to 18 months. And there's a duration of the neoadjuvant. There's benefit of the longer duration of neoadjuvant androgen deprivation therapy, but there is no consensus how many months one should give the neoadjuvant in these patients. Usually practice varies from 2 to 8 months of any. If there is a large prostate, you want to decrease the significant decrease in the volume of the prostate, then the longer androgen deprivation. Otherwise, the standard is 2 to 3 months before the radiation therapy. So there are 3 randomized trials for the immediate versus deferred TROG trial and VCOG trial, which have shown overall survival benefit has been found with the immediate androgen deprivation therapy. Whether radiotherapy alone is or radiotherapy with androgen deprivation therapy for 6 months, or relapse-free survival is in GETA-16 trial, relapse-free survival is superior than the androgen deprivation therapy when added to the radiation therapy. Whether one should do the total androgen blockade, radiotherapy with 2-year androgen with bicalutamide. Actually, the 95% of the hormone is coming from the testis, but 5% which comes from the peripheral conversion from the fat tissue and other tissues are adrenal, they can be blocked by the bicalutamide, which is the peripheral conversion into the. So when you add the bicalutamide versus the placebo along with the anti-androgen, so this study have shown the superiorly when you add the total androgen blockade with the bicalutamide versus the placebo. So these are the various trials with the neoadjuvant goserelin with the flutamide. What they have shown, this is the 2 trials. Disease-specific mortality is decreased and also the prostate cancer specific mortality is decreased when you add the androgen deprivation therapy like goserelin, and survival results with the goserelin and flutamide, radiotherapy alone versus radiotherapy with androgen deprivation therapy with 10 years follow-up. Both the studies have shown RTOG 8601, there's significant improvement in the overall survival, and also all-cause mortality also decreased in the TROG 9601 study. Then another study, the progression-free survival with the radiotherapy alone versus radiotherapy plus goserelin. They have shown the progression-free survival is superior for at 10 years, and usually the 46% reduction in the risk of progression of disease at 10 years when goserelin is added to the radiotherapy. And the progression-free survival and subgroup analysis, which have shown that most of the factors are correlated with the radiotherapy with goserelin that is favored versus the radiotherapy alone. So for high-risk prostate cancers, external beam radiation therapy along with the 2 to 3 years of long-term androgen deprivation therapy is the standard practice, and several randomized trials have shown that long-term is a standard of care. Although androgen deprivation therapy is associated with the adverse side effects, hot flashes, libido, erectile dysfunction, loss of muscle mass, fatigue, anemia, breast enlargement, depression, hair loss, osteoporosis, greater incidence of fractures, and recently this has been found there's increased incidence of the cardiovascular disease. So intensity and spectrum of these side effects vary, and these are reversible and can be avoided depending on you can decrease the androgen deprivation less than even 2 years up to the 18 months. So what we have seen from 2D to 3D, this dose escalation early, it was not possible to deliver 60 gray beyond in the 2D. So 3D, we are able to deliver 70 gray, but when we increase the dose escalation, the biochemical control of the disease is higher with the increase in the dose escalation. But it requires a special technique like the from 2D to 3D, 3D conformal, then subsequently 3D has resulted 20% improvement in the biochemical control, but at the risk of the doubling grade 2 to grade 3 toxicity when we increase the dose from 60 to 70 gray. So further dose escalation requires the IMRT with reduced rectal toxicity and bladder toxicity. If we do the image guidance, so we can further increase the doses, and to decrease the bladder and rectal toxicity, we can decrease the PTV margin, so can decrease coverage of the rectum and the bladder. Can be done with the image guidance, whether we do the CBCT, CT before imaging, before delivery of the radiation therapy, or fiducial gold markers, doing the KV images, matching all the gold markers before delivery in the radiation therapy. Thank you for your patient hearing.
Thank you so much, sir. You have covered the topic very well, and I think our students will get benefit of that. And there are some questions in chat box. Although you have covered, sir, but Saida Afsanchi is asking about indications of neoadjuvant hormone therapy.
I will just see the chat box.
Yes, sir. Indications of neoadjuvant hormone therapy.
Indications. Indications of Saida Afsan has asked indication of neoadjuvant hormone therapy. Usually the neoadjuvant hormone therapy is recommended in unfavorable intermediate risk as per NCCN classification, or DMECO classification in intermediate risk, and high risk and very high risk cases. Usually the neoadjuvant hormone therapy usually given 2 to 3 months before the start of the radiation therapy, and afterwards it is given 2 to 3 months in intermediate risk. Total duration is only 6 months. While in high risk cases, the same neoadjuvant hormone therapy 2 to 3 months, but sometime when the volume of the prostate is very large, so sometimes we have to give the larger, like 4 to 6 months before the start of the radiation therapy. Even before the surgery is also done, neoadjuvant hormone therapy to decrease volume of the prostate before taking for the robotic surgery. So basically it is intermediate and high risk cases.
Yes, sir. Okay, sir. Another question by Dr. Surbi is how to decide about what are the criteria to decide about radical prostatectomy or EBRT? Which should be given to whom?
Actually, it is a very difficult question to answer, because I asked this question to William Shipley a long time back. He has told me that it is the patient who enters which door. If he enters the radiation oncologist door, he is treated by the radiation oncology. If he enters in the surgeon's door, he taken for surgery. Even now, in high risk cases, usually the surgeon also prefer to take this for robotic surgery. In spite of knowing that extra capsular spread is there, in spite of seminal vesicle involvement is there, and most of the time apex of the prostate, apical part of the prostate is often positive in those if is taken by the surgery. And another thing is that the volume of the operation which is done by the center. There is a very nice article in which they have analyzed that center which is doing the 10 cases or more than 10 cases. That center which is doing the more than 10 cases, the margin positivity is much less. So they have the better results. So it is very difficult to decide whether we should take external beam radiation therapy or radical positivity.
Yeah, you are actually saying, sir. And another question is role of orchidectomy as ADT in current practice by Dr. Surbi.
Actually, orchidectomy is a very good, but it is a poor man's thing. But ADT, once you do the orchidectomy, so you cannot revert it back hormone. So after the ADT, you can revert back the hormone in the patients. And usually you can, orchidectomy usually have the very high osteoporosis rate. So a current practice, no one like to do the orchidectomy. Androgen deprivation therapy like the Leuprolide or Zoladex or Goserline is as good as orchidectomy.
Sir, at your institute, you are not doing orchidectomy at all.
I think still we are not doing, but few patients which cannot afford because the cost of the Leuprolide for 2 years is approximate about 1 lakh rupees at 3 monthly. So orchidectomy can be done in 10,000 rupees. So for poor man's, orchidectomy is still the choice of the treatment.
Yeah, at least we have to do, because we are dealing with most of the poor patient in our government hospital. So we are still doing this. Yeah, Dr. Rashi, you can continue.
Yeah, ma'am.
Yes.
Actually, what I feel after 2 years, we can actually, Dr. Rastogi is saying we can reverse. But after orchidectomy, we cannot reverse.
Yeah, definitely. This is the fact. This is the fact.
Yeah.
But economy is a big challenge for us. So we have no other option.
I agree, Dr. Surabi.
You can pick up next question, Dr. Rashid.
Dr. Suresh is asking new adjuvant treatment, bicalutamide or GNRH analog or both?
I think we should do the total androgen blockade.
Yeah.
I think GNRH analog along with the bicalutamide, and bicalutamide, which has already told that it can take care of the 5% of the peripheral conversion, which is comes because bicalutamide is usually the 5. It is conversion decreases into the dihydroesterone into the active run to by the alpha reductor blocker. So we can decrease the peripheral conversion by the 5% that can be avoided.
Yes, sir. Sir, are you practicing SBRT in prostate cancer in your center?
No, I have not practiced still SBRT.
Okay. And what about the hypofractionated radiotherapy 1625? Or
actually, we have still not practiced 1625. We are thinking to start now. Once we have the long term, we have already analyzing the results. We have already treated 120 cases with the image guidance and the good gold fiducial markers with the 76 gray and 38 fractions. Once we have the results of those, especially the rectal and bladder toxicity results, then we will think of starting the CHIP trial 1620.
Sir, one more thing, in CHIP trial, I think they have treated only the prostate, not the nodes.
No, we are only treating the prostate because when you see the National Cancer Database from the US, which is 14,000 patients, They have shown there is no advantage of the treating the, once you have the dose escalation. Second thing, you are adding the hormone therapy. So there is no advantage in adding the morbidity to the patient in the whole pelvic treatment.
Yes, sir. One more question is regarding matching, online matching, KV-CBCT and versus fiducial marker based KV image. Which is better?
Actually, KVCTs we do the fiducial marker. KV images, we are only seeing the gold fiducial marker. All the three gold fiducial marker we match in the AP and we match in the lateral. While the CBCT, you can match whole of the prostate within the dose volume. You can see the whole and you can paint the dose there, and you can see whether whole prostate is covered or not, whether it is rectum is coming, or you can only move up and down of the patient to avoid the rectum and the bladder. So almost it is the CBCT definitely considered better, but it takes longer time.
Yes, sir. Sir, actually, I think if bladder, we can see bladder and rectum also and guide our patients accordingly.
I agree with you, because every day we ask the patient to empty the rectum first, and then we ask to drink the water, fixed amount of water, and half an hour before, so that every day volume of the bladder and the rectal gas is usually fixed, but it is difficult because it is a physiological process. Sometimes patient have a more filling into the bladder, sometimes has more gas in the rectum. This is difficult, but still we can able to achieve much better if we do the protocol.
Yeah, the protocol is must in CA prostate patients, but to know how much the prostate is, the patient is following, that is important. Patient can say anything, so
the patient can say anything, that's right. But every time when we do the weekly review of this patient, we always ask the patient and ask them to show the bottle which is drinking. So every time he shows the bottle, every time he tells it. So sometimes, so we have to have some faith on the patient, that's all.
Sir, you are very right. You are very right. So in our institute, we are doing KB-CBCT. And I think the placement of fiducial will cost extra.
Not much, because the gold marker usually cost is 15 to 16,000 rupees.
Exactly.
And installation of the gold marker another 3,000 rupees. So within 20,000 patient can get that. And in our hospital, this is IGRT is very, very cheap. 26,000 of total treatment of IGRT in our hospital. And private, you know, it is about 3 lakh rupees.
Exactly.
So within 50,000, every treatment, including CT scan, fiducial marker placement, radiation completion, everything takes place.
So answer is, if possible, then do KV-CBCT. Otherwise, second is we have to do matching either by fiducial markers or by KB-CBCT. Sir, one more question by Dr. Neetu. Does concurrent bicalutamide with EBRT increase the toxicity?
I don't have any idea about that. Whether I have not seen anything, but I don't know whether it is increases the toxicity, because once you give the leuprolide, so leuprolide works for 3 months. If you have given before the radiation therapy, leuprolide is continuously working on the patient. So bicalutamide, I don't know, but I have not seen any increase in the toxicity in these patients.
Thank you so much, sir. I think it's the last question is professional lymph node radiation in unfavorable intermediate risk patient.
I think
Dr. Divya is asking.
Pelvic RT, whole pelvic RT is not recommended now. So I think there is no role of prophylactic lymph node irradiation even in high risk. GETAC trial, if you see the French trial, 50% of the patients were high risk. In spite of that, and they have given the hormone therapy and prostate only RT versus whole pelvic RT, there is no difference. So I don't think there is any point in treating the lymph node and increasing in the toxicity in these patients.
That is it, sir. So I think
So what is your policy, Dr. Rashi, regarding the whole pelvic versus the prostate only radiation therapy in your house, in your center?
Dr. Rashmi, you are not audible properly. Not audible. I think some network issue. So thank you so much, Dr. NEERAJ RASTOGI, sir. It was such a nice and comprehensive lecture given by you and very informative, obviously. For final remark, I would like to invite Dr. Shaleen, sir. Sir, is here?
I think Dr. Shalin want to comment something.
Yes, sir.
No, thank you very much. There is at least some clarity about what to do and what not to do, particularly with regard to the treatment of the pelvis, the pelvis, the pelvic lymph nodes. So that was one clarity. I'm a bit intrigued about this data, about the fact that in the low risk prostate cancer, when you are doing surveillance versus intervention, you have shown that the overall results of the trial were that surveillance was inferior in terms of overall survival. But then I think that trial also suggested that it was confined only to patients who were less than 65, where the benefit of radical prostatectomy was seen, but not over. So can we have, do we have any firm guidelines on who can actually undergo surveillance when there is localized prostate cancer and it is classically low risk? Is there any firm guidance? Because this trial seems like a subset analysis. Can you just comment on that as a final comment? Thank you very much, sir.
Actually, usually the patient which are taking in the surveillance, usually more than 75 years, these are the patients with the comorbidity. So usually these patients are maybe life expectancy is less than 10 years.
So, you know, life expectancy is not.
Performance status is also important in these patients.
Okay. So it isn't the age cutoff as much as it is about projected lifespan and
it depends on the country to country. Like US, they have all the data is from US. So whether the life expectancy is higher.
Okay. Is there any role of surveillance?
You have the comorbidity higher there.
Is there any suggestion that in the intermediate risk, but more than 75 and comorbidities, surveillance is a possibility? Is there any indication, any such indication, any such data available in literature?
I don't know actually data, but it is not recommended in intermediate risk at all.
All right. Okay. Thank you very much.
Maybe we can give the shorter fractionation in those patients. Not coming 7 weeks, can bring it down to 4 weeks or maybe less in these patients.
Yes, but to the extent I understand, the shorter fractionation has its merit because of the lower alpha beta value. And so in effect, it is equi-efficacious to the standard fractionation, larger total dose story.
Yes.
So, but it's convenient. That is agreed. Okay. Thank you very much, Dr. Rastogi. That was
Thank you,
very
Dr.
comprehensive. Thank you for taking out time. And I think it was fantastic. I think we can close, Dr. Surabhi.
Yes, sir. Thank
All
you
right,
so much,
thank you.
Dr. Neeraj, sir. Thank you, Dr. Shalin, sir. Thank you, Rashi. Thank you, all the participants. Once again, thank you so much, sir. And good night, everyone.